Okay, great. I can start. So let me see. Put them down, please, so that when you have a question, I'll be able to see. So somebody has just highlighted that they couldn't see the slides for the lecture, so I have just shared them. So make sure if you don't see them, let me know. We're going to be dealing with regeneration. So many windows open, I can't see what I want. So let me know if you are not able to see this or to hear this, but it is on Blackboard. So I'm trying to show you visually some of the things that I'm going to discuss, which should make things easier for you. Are you able to see the screen?
Yes, Prof.
Yes.
Regeneration of nerve fiber. In this topic, we're going to be dealing with the criteria for regeneration and the stages of regeneration. The term regeneration refers to regrowth of lost or destroyed part of a tissue. An injured and degenerated nerve fiber can regenerate. It starts as early as 4th day after injury, but becomes more effective only after 30 days and is completed in about 80 days. Criteria for regeneration. Regeneration is possible only if certain criteria are fulfilled by the degenerated nerve fiber. The criteria are as follows. Gaps between the cut ends of the nerve should not exceed 3 millimeters. Neurolemma should be present. As neurolemma is absent in CNS, the regeneration of the nerve does not occur in CNS. Nucleus must be intact. If it is extruded from the nerve cell body, the nerve is atrophied and the regeneration does not occur. 2 cut ends should remain in the same line. Regeneration does not occur if any one end is moved away. Stages of regeneration. First, some pseudopodia-like extensions grow from the proximal cut end of the nerve. These extensions are called fibrils or regenerative sprouts. The number of fibrils is up to 100. Fibrils move towards the distal cut end of the nerve fiber. Some of the fibrils enter the neurolemma tube of distal end and form active cylinder. Some of the fibrils enter the neurolemmal tube of distal end and form active cylinder. Schwann cells line up in the neurolemmal tube and actually guide the fibrils into the tube. Schwann cells also synthesize nerve growth factors, which attract the fibrils from proximal segments. Active cylinder is fully established inside the neurolemmal tube. These processes are completed in about 3 months after injury. Myelin sheath is formed by Schwann cells slowly. Myelination is completed in 1 year. Diameter of the nerve fiber gradually increases. However, the degenerated nerve fiber obtains only 80% of original diameter. Newly formed internodes are also shorter than the original ones. In the nerve cell body, first, the missile granules appear, followed by Golgi apparatus. Cell loses the excess fluid. The nucleus occupies the central portion. Anatomical regeneration occurs in the nerve, functional recovery occurs after a long period.
So was the audio clear?
Yes.
Yes. Because I've had issues in the past where you are able to see, but the sound is so low you can't hear. So I don't know what happens to it. So today I want us to start on the nerve damage and repair. So for those people who are recording, I forgot to tell you, or even you should have stopped the recording when you are having a break. So this video will become very long. So I would advise you to stop recording so that you end that other recording. Then you'll have a different video for nerve injury and regeneration. So keep your hands up. Stop. If you stop the recording, it will start converting and you won't be able to record another one. So I'll need a fresh hands to do the recording if you have already stopped. I can see some are still recording. Those ones will be able to have a very long recording. So let me get some other hands so that okay, I have Aiden and Anita. Let me give you rights. Yeah, so the others have started converting. I'll need a third hand.
Hello, Prof.
Yes.
Please, I stopped recording and this is like another one I'm doing right now. So I don't know.
Oh, this is another one. Okay,
Yeah,
great.
yeah.
And in that case, we are good. Yeah, so because I wouldn't want to have a very long recording which you cannot even upload. So with that, let's start with nerve injury. I think I have touched a bit on this in the previous lectures that we have had, where we say that you may have damage to part of the neuron, and if it normally happens on the axon part, then repair is possible if it is peripheral or if some circumstances prevail. So before we do that, before we look at the injury, the type of injury, the circumstances, we need to know what the nerve looks like. So the first thing I will address very quickly, which I have also touched on, is the structure of the nerve. Then we'll see what is nerve injury, what are the causes of the different nerve injuries, what are the classifications of the injury, what is neurodegeneration, and what is neuroregeneration. Then finally, we'll see what are the factors that affect neuron regeneration. So when you look at the nervous system, it is equated to electrical wiring in your body. So in the house, you have cables which are running all over and they provide light at the right place. They provide a switch at the right place. So the same way your body is wired, it has fibers running from one point to the other, delivering information. So if you look at the way they are organized, those fibers, the axons, are organized in bundles, and these bundles, the largest bundle that you're going to get is the nerve. If you cut through the nerve, you'll see something similar to what you see in electric cables. So in an electric cable, you'll find usually we have a copper wire or a conducting wire right in the middle, and this wire is usually insulated so that whatever electric conduction is happening here, it is not going to the neighboring areas. So you are going to find it has a cable or a plastic non-conducting insulation layer on it. Now, This ensures that there is no transmission of electric activity between one part of the wire to the other one. Now, similarly, in the body, we have the axons, and the axons are acting like these electric cables. So you have to have an insulation layer around that axon to prevent this electric activity from leaking to adjacent neurons. Now, this small cable or this small conducting cable is organized such that you have quite a number of cables. You can see in this case, you have tiny different colored wires or cables, but right in the middle you're going to find it has a conducting cable, which is usually copper, and they are held separate from each other by the plastic lining. If you look at them, if you enlarge and you look at them, we have different types of cables, some with just a few conduits, and each of them has a plastic lining around them, and then they are held together by a bigger bundle. And you can have others with more cables and with a larger bundle held together. You can have of different types, so that if I look at this one, maybe it is representative of this cable, but then on top of that we have the black one which holds all the gray ones together. This is simply to help in organization, so that you don't have all these loose wires crisscrossing around your house. So, how would you know the cable that is on one end should be connected to which part on the other end? That is why the plastic lining is coded, so that if I take a cable on this side and it is green, and I follow this conduit to the other end, and I look for the cable that is green, I know it is the same one. Then I'll be able to hook it to the correct place. Similarly, if I take a yellow one, I can also track it and I'll be able to hook it to the right place. So even the neurons, they have a similar arrangement. A neuron coming from a specific place will get into one bundle, and it will go and end up in a specific place. And it is always the same. It's not random. It is very well organized. So with this idea in mind, we will enlarge a neuron and see what it looks like. So this is a diagram I have shown you in the past, whereby if you take a whole nerve, you go to the anatomy lab and you take some tweezers and you just lift up one nerve, then you cut across it. You're going to see structures which appear as bundles. These are bundles of neurons, and another name for bundle is they are known as fascicles. So we are going to have all these fascicles here, which are the bundles. If I extrude one of these big bundle here, you find that it is surrounded by some of these blood vessels which are supplying the neurons. And remember, when we are looking at the types of blood cells, we say there are some macrophages, and you'll usually find that they will be rich even within the nerve. They are there, always doing cleanup. And because of that, since we have the blood supply, the macrophages are able to easily get into this area, do their cleanup, and get back into the blood system. Now, if you take one of these bundles, you find that within it, it has more bundles. So we have the large bundles or more fascicles, and then within it, it has some other smaller bundles. And if you extrude one of those, you'll find that it is made up of individual axons, which could be myelinated, like in this case, the yellow part is the axon, and the bluish part looking here is the Schwann cell making up the myelin sheath. On the other hand, it could be unmyelinated, which is just appearing as a single yellow fiber. You can see even with these fibers, some of them are big, like the one I'm pointing at here, has a larger diameter as compared to this other yellow small one, which has a smaller diameter. But as we are looking at classification of nerve fibers, we saw that even in the unmyelinated, they differ in diameter. Similarly, if you look at the diameter of this one, it is much larger than this other one, and yet they are both myelinated. Now, the other thing they have not shown here, or it is not visible here, is that when you have an axon and you have all this myelination, we usually have another thin membrane of connective tissue that surrounds these Schwann cells or the myelin sheath. And that is the membrane that is appearing pinkish in this diagram to the left. So we have the yellow component, which is the axon. Then we have the bluish area, which is making up the Schwann cell. But you find that it has a thin layer of membrane that holds all that together. It's a connective tissue. So this thin layer is known as the endoneurium. So anything related to connective tissue holding the nerves together is referred to as the neurium. So this part, this name, neurium. You able to see that?
Yes, Prof.
Yes.
Okay.
Yes.
So keep that in mind. Neurium, it is like the membrane around the neuron. Neu for neuron. Rium is the membrane around the neuron. So we have the innermost will be called the endo because it is innermost than the others. So I think I will give you the next diagram so that you can relate to it. So in this diagram to my right, it is showing you an image of a neuron that is coming from very far, and it has two major bundles here. And then from this one bundle, it has other fascicles. Pull out one of the fascicles and then pull out, you find the individual neurons. Similarly, here is just a schematic representation of the same, with the yellow covering being the neuron, but you can see the fascicles in here. So the next one, yes, so in this diagram, it is showing you the same neuron here, but then you rip out the top covering. As we are going to come and see later, it has what we call the paraneurium. So we have the paraneurium, which is the outermost. It's the one that you're going to see here, the paraneurium. Then among them, you pull out a bundle or a fascicle. And you find that that fascicle is held together by what you call the perineurium. So remember the word, neurium, membrane around the neuron. But peri is inner than the para. So we have peri, first is para, peri, and then we are going to go into the next one. So from the perineurium, you are going to go to the inner one that is surrounding the individual axon. It is the endoneurium. So come from endo, go to peri. Actually, there is also another one which is the epineurium. So we have endoneurium around the axon. Perineurium surrounds the first bundle that is holding the individual axons. Epineurium holds all this perineurium together. And then you can have two bundles and they are held together by a neurium. So like what we had here, you can see that on the outside, holding these two bundles together are the paraneurium. Then the one that is holding the fascicles together is the epineurium. And then you have the perineurium, and then from the perineurium, endoneurium. So if we were to write them, I have not written this down, so I want you to note. The outermost is paraneurium, and the next one, more inner than that, will be the perineurium. And then surrounding that one, we have the epineurium. And then from perineurium, we're going to have endoneurium. So from there, you're going to get the myelin sheath. And then from there, you have the axon. So it's good to remember the differences between all these so that you are able to relate. So I think from this, you can look at that diagram. So I've put them together for you here. So coming from the para, epi, and then peri, and then endoneurium. So you may wonder why I'm giving you anatomical names, but you find that this will become important when it comes to repair, because the extent of damage will be dependent on how far which of these membranes have actually been damaged. Have you damaged the endoneurium? Have you damaged the epineurium? And what kind of repair are you going to get? Yes, Asna.
Oh, I wanted to ask, could you give me the difference between epineurium and paraneurium? They're confusing me, the two.
So if we have big bundles, each having an epineurium, you find that whatever surrounds them will be a very tough tissue, which is normally the paraneurium. And usually these large bundles are not many. You can have a nerve having only one big bundle or two big bundles. Occasionally you may have a third small one or something of that sort, but usually they are not many. So the one that holds the largest bundle, it will be the perineurium, but the one that, I'm even getting confused now. The outermost is the paraneurium, and then the next one will be the epineurium. Together now?
Yes, thank you.
Okay. So actually, if you want to remember, just keep in mind the diagram that I had shown here. This one it is more clear, only that then I have enlarged it so that you can see the diagram. So the writing may not be clearly legible, but you can see this part that is cut here, that is the epineurium. Okay, then we have the paraneurium is the one that is lifted with the tweezers. So the tweezers is lifting off the paraneurium, but surrounding this big bundle is the epineurium, and then for each of these bundles they are surrounded by the perineurium.
Thank you.
Okay. Now, having understood that, the other thing you need to keep in mind is that when we have these neurons, we say they are bundles of axons. And the bundles of axons are either coming from a sensory cell or they are themselves specialized neurons with terminals that are able to pick up sensations. If that is the case, the information will be going in that direction. That means they are sensory neurons. A good example coming from the skeletal muscle, we have just discussed that we can have two types of sensory neurons coming from the skeletal muscle. Anastasia, can you tell us one? And let me choose somebody else. Steve Denver, tell us the other one. Anastasia, one of the sensory organs coming from the muscle.
Sensory organs coming from the muscle.
Yes, one, just one. A sensory receptor. It's also an organ. It's a small structure, but it's an organ. Sensory receptor coming from the muscle. There are two of them, and we discussed them in the previous lecture. Just give me one. Anastasia, yes?
I don't know.
Were you in class in the previous lecture?
Yes, but I came in late. I'm sorry.
Oh yeah, even if you came in late, I talked about it several times. So remember, I will call people randomly, and you're supposed to let me know that you are attentive in class.
Are you talking about the spindle fibers?
Yes, that is one of them. So Denver, which is the other one? Denver, if one of them is the muscle spindle, which is the other organ that is coming from around the muscles or towards the end of the muscles? Denver, are you in class or I put you in waiting room?
I'm in class.
Okay, kindly respond.
I'm not sure.
Which receptors sense movement? Which receptors are responsible for
The
detecting
Golgi tendon
motion?
fiber.
Pardon?
Golgi tendon fiber.
The Golgi tendon fiber, exactly. It is very easy to say you don't know, but actually, I know all of you are aware of it because I've been talking about it in class. I've talked about it here. So there are two receptors, the Golgi tendon organ, and the other one is the muscle fiber. I mean the muscle spindle. So if this neuron is coming from deep into the muscles, it may be originating from a muscle spindle. But if, on the other hand, it is coming from the tendons, then it is a Golgi tendon organ, and it will be taking information regarding stretch, either the stretch of the tendon or the stretch of the muscle. Then in that case, it will be a sensory neuron. But in this case, you've been told this is a motor neuron. It means that it is innervating the muscle. So the direction of conduction is towards the muscle. And what you have here is a neuromuscular junction because it has a nerve terminal which ends up in the muscle. Or if the neuron embeds itself into the inside and then it distributes, you find that at the end of the neuron terminal, we have the neuromuscular junction. So with this in mind, we know that the CNS is on this side and the effector is on this side. And what is connecting them is the motor neuron. So the question is, what happens if you are to damage right there in the middle? And this usually happens because the neurons or the nerves are spread out to the periphery or to your appendages. You find that it is very easy to cause damage on a neuron. If that happens, it means you're going to interfere with conduction. But the question is, to what extent have you caused this damage? So you find that nerve injury could occur due to so many different things. When you're seated in one position and you're pressing on a part of your thigh, there is a nerve there, and you are likely to cause compression, applying too much pressure without relieving it. It will mean that it will reach a point when you start feeling numbness. And remember, from my previous lecture, we said that pressure will affect different neurons in different ways. So among the ones which are most susceptible, we say there are neurons which are innervating the muscles. So we are talking of the A category. They are the ones which will be susceptible and you'll easily damage them and they'll stop taking the conduction. However, we still have sensation of pain. So you'll be feeling there is some pain, but you cannot feel touch, you cannot feel things like a muscle moving in that area. So that is one type of injury. Now, the question I want to ask you, this type of injury, do you think it is reversible or irreversible? Axilla.
I think it's irreversible.
You think it is?
Irreversible.
Why do you think so? Why do you think it is reversible? You know, it is very easy to ask you, is it black or white? And you just choose white. And you don't give me why. You have to have a reason. Why did you fall with the answer it is reversible?
I'm not sure why.
Okay, how many agree with Axilla? Only one person. Okay, let's see. I will check the people who are in class. So people have put up their hands. I want to see those who disagree. Don't put down your hands, kindly. Those people who have put up their hands now, do not put them down. Those who disagree with Axilla, I want you to put a tick against your name. Those who disagree with Axilla, I want you to put a tick against your name. Okay, those who don't know, put an X against your name. Those who don't know, put an X against your name. So I think I have Axilla, you agree with yourself. Put up that hand. I want to know where Madeline is. Okay. So there is one person who was not in class. Anim. There was one person, Madeline. Madeline, where is she? She's gone out. Okay. So I want one of the people with the hands up. Just tell me why you agree. I won't ask Michelle because she has no clue what we are discussing. Mobusu. Oh, Michelle, are you following the lecture?
What I'm saying is that anything is possible. It can be reversible or irreversible in any circumstance, whether there's impulse or like regeneration from a certain point.
Okay, okay, thank you. At least I've had one opinion from you and we'll tackle it. Yeah, I just don't like people who say they don't know because they were not following the lecture, but I'm glad that to hear you are following it. Patience, you disagree? Why?
Yeah, I disagree.
Why?
I think that they can regenerate.
Okay. So one of the people who support Axila said she agrees. Yeah, it is reversible, but she has no clue why. So I think she's one of the people who chooses it's either black or white, and they just decide to take. Is it heads or tail? I'll take tails. Okay. Somebody just let me know. So everybody can put their hands up, hands down, but the person who has a clue, just unmute yourself and then hear your opinion. Whoever has a clue, unmute yourself and tell us what you think. Go ahead, Winnie.
I think it is because it is just a mere compression on the myelin sheath, the outer layer. So I think it is reversible.
Okay, if you think it is reversible, it's not affecting the myelin sheath. Okay, kindly the others put down your hands. I will ask you to think like a non-physiologist. Stop overthinking what the neuron looks like. Stop overthinking what is inside your body. I simply want you to think what happens when you compress your part of your body and you start feeling numb. What happens if you remove that compression? Do you still continue feeling numb?
No.
How many still continue feeling numb after they have removed the compression? So the
Hello, Prof.
question is, have you regained sensation?
Hello,
Yes.
Prof.
Yes?
I think after you remove it for a while, you still feel numb, but with time, you start regaining feeling on that part of the body.
Thank you. So after some time, you'll start feeling the sensation. So now you have regained its function. So have you repaired whatever you had damaged?
Yes.
You
Yes.
have repaired, isn't it? Now that
Yes.
brings the issue of, have you reversed the damage? First, you caused damage so that you stop feeling the sensation. You remove the cause, and when you remove the cause, the nerve itself slowly restores its function. So you have reversed the damage. So compression is reversible. Yes, Asna?
What is it that feeling you get like pins and needles after you remove the compression?
Now, those are some of the things they are trying to understand. What happens during compression damage? So initially, it was thought that at that point, whereby if you take an axon, it's like a tube. And inside this tube, we have axoplasm. And at the same time, we have channels here on the membranes. So when you have an action potential coming, you find that at this point, once it reaches the point of compression, so if the compression is here, you find that when it reaches here, it was initially thought that the damage is because the nerve conduction cannot go any further than here. However, they found that what happens is when you compress this nerve, the axoplasm will spread to this area and this area, so that this part which is compressed becomes very narrow. Now, because you are pushing away the axoplasm, you are causing a bulge here, and you are causing another bulge here. Now, these bulges that you are causing, they are sort of causing some sodium leakages. And you find that because it cannot move from here to that end, it cannot communicate. When you remove the compression, there will be a flood of all these places, allowing the sodium to pass. And that is the one that will cause all the sensations that come after you remove. But that is a theory. That is somebody who has come up with that theory. It has not yet been proven. But it is assumed that that is what happens. And probably it can account for the sensation that you feel immediately you remove the compression. Okay?
Okay.
So now there is also the crash injury. Now, the crash injury is slightly different, not really slightly different. You can imagine when you come and you hit on a nerve, a wide area of the nerve, and what you're going to do is like flattening and causing real damage of a wide area. The type of injury that you're going to cause here, it may cause the axons to split. Okay? Now, if that happens, then you find that it may be reversible, it may not be reversible, depending on the extent of the damage. Now, when it comes to stretch, I'm sure most of you have encountered this damage. Okay? So you are going to try and get something, and all of a sudden you are stretched beyond what is your normal. And what happens is that if you had an axon, a neuron, you may go and still holding. Remember we talked of the epineurium, maybe I should give a different color. No, not the epi, it's the endoneurium that was surrounding the myelin sheath. So you may stretch such that you cause damage, breaking of the axons, but you leave the myelin sheath and the endoneurium intact. That is as one type of damage. Again, depending on how much the stretch is, you can also have repair or regeneration occurring. Now, toxins. Toxins may be widespread because, like I told you, they may spread along the myelin sheath. And if you remember, when we are talking about the extent of repair, will be dependent on the space of damage. So it is over 3 millimeters between the end, the proximal end, and the distal end. If there is more than 3 millimeters damage, then you find repair in such a case is difficult.
Excuse me, please.
Yes?
Yeah, I have a question on stretch.
Yes.
Okay, I've not understood really. Are you talking about the stretch increasing diameter or the length of the...
Now, in most cases, it is the length. So if you have that length stretch, but even the other one that I have just showed you, where you are stretching the diameter, it will also cause some damage. But in that one, it will be repairable. That one can be repaired. But the one of length, if you stretch it out, you will also cause damage of that nerve. But depending on, if you have stretched it enough to cause the cutting or the severing of the axon, then the extent of repair will be slower than if you had just simply stretched the neuron and then after some time you restore it to its original length and then it restores function. So it will depend on how much you stretch, whether it is lengthwise. If it is diameter-wise, it's like the one I had just given you before. Okay. So the next one I have talked about toxins. The problem with toxins, they can be diffuse. They can just go in, damage different areas to different extent. So repairing toxins, first and foremost, you need to clear the toxin. get it out, and then you start repairing the points of damage. The other cause of damage is when you have ischemia. I talked to you about obstructing blood flow, resulting in hypoxia. In some areas, you deny that region oxygen. Now, when there is total obstruction of the blood flow, you result with a situation whereby it is not only the oxygen you are denying, you are also not allowing blood to flow to that region. You are not allowing waste materials to be moved from that area, so they start causing damage beyond the point of occlusion. So this damage can actually even lead to tissue death. But among them, remember, in that area, we also have some neurons that have been innervated. They have innervated that area. So if that is happening, even those neurons will be damaged and you start losing sensation. Question is, can you repair it? Again, dependent on extent of damage. If you are able to remove the blood obstruction, the blood flow obstruction, then you can repair it, because the body has a system of cleaning itself up. If, on the other hand, it is prolonged, then it will take a longer time to repair. Then there is the more severe. The more severe one is when you have transection of the nerve. We've been talking about damaging the axons, maybe due to stretch. Damaging the axons may be due to crushing the nerve. What happens when you have a complete severing of the nerve? And this usually happens when you have cuts. So maybe you have a big, sharp object that comes and slices a part of your appendage, your arm. Among those things that will be cut will be the nerve. So if you cut a whole nerve, what happens? Can you be able to repair it the same way as you repaired compression, or the same way as you repaired the crack injury? So it will be dependent. When it comes to the transection, you find that the chances of repair are lower, so much slimmer than when you have the other types of injury. So let us classify the types of injuries. So I will come up again with two different types of classifications. We have what we call the Seddon's classification, and then we have the Sutherland classification. So I don't want you to confuse these two classifications with the ones we have just talked about, nerve fiber. In this one, Seddon, when you think of Seddon, think in terms of repair. Yeah, we are repairing, and the Seddon comes with Sutherland. They are both S's. Three types in the Seddon. Type 1 to 4 in Sutherland. Okay, so let us look at the three types. It was simply looking at which part has been cut. If you have not cut any region, and the only thing you did not cut the neuron, the only thing you did was to compress it, then that compression damage is known as neuroplasia. It corresponds to type 1 of the Sutherland's classification. So you compress a neuron, and then you relieve the compression. It is reversible. It is the least type of injury. In fact, you refer to it as the first degree. It is the smallest type of damage you can cause to a neuron, and it is reversible. After you move from compression, now you start to sever the axons. So the first level of severance is when you cut the axon, but you leave the other connective tissues, the epineurium, the endoneurium, when you leave them intact, but the axon itself has split, then you call that axonotomesis. Axonotomesis because it is cutting of the axon. There are several levels of axonotomesis, and we are going to look at them. Then we have neurotomesis, when you cut the whole neuron. You've cut the neuron and you've cut the different levels of the connective tissues. So if you have only the axon that has been severed, then you have type 2. All the other connective tissues are intact. So in type 1, the nerve fiber is intact and the covering connective tissues are intact. In type 2, the axon has been cut, but the covering connective tissues are intact. Now, in type 3, 4, and 5, you find that there is severing of the axons. But in addition, type 3, you have damaged the endoneurium. Type 4, you've damaged to the level of the epineurium. And type 5, you have damaged all those connective tissues. So depending on what level you have damaged, it will give you type 3, 4, and 5. So in this case, it talks about damaging the connective tissues and damaging the axon. It is the 3rd degree type of injury. Second, only the axon. Type 1, none of them have been cut completely. So if you look at the images, there is a publication that I have posted on Blackboard, which is talking about nerve injury. In fact, the publication is this one, Mechanism of Injury and Recovery. It is in the Handbook of Clinical Physiology and Neurology. So what you find is that you can read the whole paper, but I have tried to summarize for you here, where we have all the grades that we have talked about, type 1 all the way to type 5 according to Sunderland's classification. So from this, you find that in this case, the axon, which is the blue line, is intact. What could have happened is you could have damaged the surrounding area, especially the myelin sheath. So the endoneurium is still intact. Remember, the endoneurium is the one that surrounds the myelin sheath. It's still intact. All the other regions, the epineurium, the fascicles, everything else is intact. Now, in this kind of injury, if you remove the compression, usually these neurons, these axons, sorry, I think now I'm sleeping. These Schwann cells that were damaged here may actually disappear, but you can easily repair them. There are always satellite cells here which are always ready to remyelinate and to restore full function. So in some cases, you may have compressed to the extent that the Schwann cell is not damaged, but if it is damaged, it can easily repair. So that is grade 1 or type 1. In type 2, you end up causing cutting of the axon, but the other things are, everything else is intact. All the membranes are intact. All the other neurons are intact. Then in that case, you find that it will be very easy to repair, because this neuron that has been damaged will start to develop sprouts, and these sprouts are going to grow into the endoneurium that was left behind, and they'll end up innervating the effector tissue that it had innervated initially. Now, when you go to grade 3, you move from the endoneurium, you start causing damage now to the perineurium. So you have caused damage to the perineurium, but the other things are intact. In grade 4, you cause damage, when you cause damage in grade 4, you cut everything, even the epineurium. In this other one, you find that you can cause damage to the endoneurium, but the epineurium is left intact. In the last one is when you cause severing of everything. When you cut everything and you need to repair. So grade 1, 2, 3, 4, and 5, depending on which level you have cut off. So to represent that in a tabular form, we have Sunderland's classification of 1, 2, 3, and 4. Seddon has only 3 classifications. When you have praxia complexion, when you have severing of the axon, which is axonotomesis, and finally, when you have severing of the membranes, when you talk of neurotomesis. So Seddon's classification is very simple. Sunderland's, on the other hand, goes to the extent of what do you see. In neuroplaxia, you can have just simple compression, and then from there you can have demyelination. When you go to axonotomesis, you'll have both demyelination and the axon severing. When you go to the grade 3, you're going to have that demyelination, axon loss, and in addition, you cut off the endoneurium. But all the others remain intact. In grade 4, you involve the perineurium, but the epineurium and paraneurium are intact. In grade 5, you sever everything, including the epineurium, the paraneurium. Then you have the most severe form of damage. So what you look at, the grade of or the level of damage, the least damaging is the type 1 neuropraxia, which is compression. The moderate one is the axonotomesis, because this can easily repair. And we are going to see here the prognosis, that is the extent of repair and how long it takes. So with the mild one, it is almost immediately, but depending on whether the damage had involved the Schwann cells. If it did not damage the Schwann cells, such as a good example is when you press on your hand or press on your limb, it means that when you remove the compression, it easily repairs because everything else is intact. What you normally find is that it blocks conduction. You stop feeling, but remove the compression and you restore conduction. If you had severe compression to the extent that you demyelinated, you removed or caused damage to the Schwann cell, then it means the Schwann cells have to come and infiltrate that point of damage and cause remyelination. For that reason, that extent of repair can take even up to 3 months because you are repairing now the myelin sheath. The second one, when you have axonotomesis, causing both demyelination and cutting of the axon, then what will happen is beyond the point of injury, you are going to have an axon loss or degeneration. You remember the talk I mentioned about Wallerian degeneration. So whenever you have the axon has been cut, then the point that is distal to that cut in region will degenerate by Wallerian degeneration. The proximal end will end up forming sprouts so that they'll end up colonizing or going back into the myelin sheath. And remember, not the sheath, the endoneurium, because the endoneurium has been left intact. So you find that if you look at the type of repair, it is usually good, but it is also limited by two things. How long is the cut region? Is it more than 3 millimeters? If it is more, then it takes longer to repair or not at all. If it is smaller than that, then you find that you're going to have good repair. The other component is the time factor. How long did you take between the time of removing the damage or cause of damage and initiating repair? What does that mean? You can have a crash injury where you place some substance or you crush something very heavy on the neuron. If you do not remove that crash object, it means that for a long time you'll have that damage, will have blood, will have infiltration of the immune response. You know that things that are happening in that area. It also means that you'll take longer to start cleaning up that injury site. If it takes longer, it means that even the repair takes longer to occur. Now, in the other one, you can see that as you continue cutting the connective tissue, the prognosis becomes less and less, with the least chances of repair when you have neurotomesis, severe neurotomesis involving everything, including the cranium. So, any questions so far? So, what we have in the left column, Sunderland's classification. In the next column, Seddon's, the grade or extent of damage. Pathology is what you actually see, or what does it involve? Remember what we talked about? Pathology is the structure. Which structure has been damaged? The physiology or pathophysiology looks at the electrodiagnostic effect. Do we have conduction? No. If it has blocked and it is restored, then it was just a simple block. But when you cut the axon, it means that the conduction terminates at the end portion of the proximal region. Then prognosis is the extent of repair and how long it takes. Is it good? Is it fair? Or is it none at all? And how long does it take? So you find in this poor or nil, this is usually what you find in cases where somebody maybe had a spinal injury or maybe had injured the limb and they had totally lost sensation, they had totally lost functionality of the neurons. But after so many years, they start recovering, and of course with the physiotherapy, they slowly start recovering some of their sensation, but not all. That's why we say it is poor. With good and fair, you find that there is some repair. Like I gave an example in class whereby you find I damaged part of my nerves in the foot, but with time I have recovered most, if not all, but it is not yet back to the 100% it was before. Then with a good repair is when you have severed a part of your, let's say for example, you've cut a part of your hand and you have actually touched some of the neurons or you have crushed them. You find that with time, as the hand heals, even that part, it regains sensation. So I think from there, I will start discussing the stages of repair, the type of nerve injury, and the type of repair that we are going to see. So because I have only, I think, I have very few minutes. I don't want to start this because it will take some time. I don't want to start something totally new. So I want us to focus on what you have captured so far. Alisa Keller, can you tell me what you have captured so far?
Hello.
Okay. Yes?
Can you hear me?
Yes.
Okay. I've gotten on the types of types of nerve injury. We have the saddle and the Sutherland. They are classified into two.
Okay. Now let me do this. I have 10 minutes to take attendance. If you need to be known that you are in class, I need you to tell me what you captured and I tick you at your presence. That's how I will take my attendance. So you tell me who you are. You tell me the group and what you captured. Do not repeat. Do not repeat what somebody else says. So kindly let me know who you are, what you have captured. Now, because this is the way I'll take attendance, I want you to put up your hand. So the first person puts up, they mention something, then they can actually, what will they do? You leave your hand up so that I'll go according to the way the hands have come up. So Maria, you tell me the group you are in and then give me the answer.
Group 1?
Yeah? You are Maria Jonawala?
Yes, yes.
Okay, what did you capture? One thing.
Only one, okay. So the causes of nerve injury.
I don't want you to hold everything, then somebody else doesn't have anything to tell me.
Okay,
Yeah?
the causes of nerve injuries.
Okay, just hold on. Just hold on. I know people are very clever here. Okay. Causes of nerve injury. What did you say?
Yes.
Maria?
I said we learned the causes of nerve injuries like compression, crush, stretch.
Okay, there you are. The next person, don't put your hand down because I want to take attendance for everybody. Anastasia, group what? Give me your last name, Anastasia.
Bambi Munjuri. I'm in group Y.
Okay, I've seen you. Quickly.
Yeah, I've learned the neuroplasia form of damage.
What is neuroplasia?
Yeah, it's okay, it doesn't damage the axon, it's reversible. It's the first type of damage that is.
And remember, okay, thank you, Anastasia. You can give me something you have captured even in the previous class, the one we did in the morning. So quickly, Eden. Eden, which group? Mustaf?
Group Y.
Okay.
Yeah, I've learned the second type 2 injury, which is axonotomesis.
Yeah.
It involves both damage of the axon and its surrounding.
Okay, Cecilia, quickly. Cecilia Selem.
Yeah.
Yes. Quickly.
Group Z, and my take home is the sensory neurons, the two types, the musculospinal and the Golgi tendon organ.
Okay, thank you. Joy Moshemi, which group?
Group Z.
Okay, I seen you. Quickly.
I've taken home the order of the layers, the perineum, epineurium, perineurium, endoneurium, myelin sheath.
Okay, thank you. Grace Mugambi, which group? I've seen you. Quickly.
I'm in group Z.
Yes.
The sensory receptor or organ coming from the muscles are the musculospinal receptor and the Golgi tendon fiber.
Okay, and please don't repeat what the previous person has said. Okay, that was Grace Mugambi. Don't put down your hands. If you put down your hands, I'll end up calling you again, and I don't want that. So I want to take I've just come from. Okay. If you answer, do not put down your hand because I'm taking attendance. Prince Moses, you're the next one.
So from the first lesson, I learned
You are in which? Yeah, I've seen your name now. Quickly tell me and be loud enough.
I'm in Group Z, and from the first lecture, I learned about the Liangagesa, and it has type A, B, and C. Type A is divided into A alpha, A beta, A gamma, and
Thank you, Prince. I don't want you to answer everything. Then the others don't have anything to say. Jockey? Waweru?
I'm in Group Y.
Okay.
Yes, I'm in Group Y. I learned that obstruction of blood flow causes nerve injury and it also results in ischemia.
Okay, thank you, Charity Ruguru. I've seen your name. Quickly say, I've seen you in group whichever.
I've learned that the postganglionic is a motor nerve.
Thank you. Sebata? Sebata.
I'm in Group Y. I've learned that the different classifications, Elangasa, and the differences is that Elangasa has motor and sensory, while Lloyd only has sensory.
Okay, thank you. Lojore. Lojore.
Yeah, sorry. So I'm in Group Z.
Yourself. Oh, yeah. Go ahead.
I'm in Group Z.
Yeah.
So I learned the hypoxia. The most susceptible is B, and the less is C.
Okay, great. And I want to go to Kakenya. Kakenya.
Yes, I'm in Group Z. What I've learned today is that...
Before you go, I want to see your name. Let me look for it. What's your other name? The last name?
Murunka. Murunka.
Murunka. Oh, yeah, I've seen you. Okay, go ahead.
Yeah, the classification of nerve fibers. The Langaza system uses the ABC system, while the Lloyd system uses the Roman numerals.
Okay, Anim, Alice?
I'm in Group Z. Can you hear me?
Yes, we can hear you. I've seen your name already.
Nerves with larger diameters provide less resistance and therefore conduct faster impulse transmission.
Okay, thank you, Nicholas. You're the next one.
Okay, so I'm in Group Y.
Okay.
I've learned that A fibers have largest diameter, then B have intermediate, then C have smaller diameter.
Okay. All right, the next person is who? Steve Denver.
I've learned that the nerve fibers can be classified depending on their location, the way where the location they connect to the CNS, the origin and the target information, the conscious input, and the myelination.
Okay, let's go to Grace Tuku.
I'm in Group Y. I learned that the Elangasa classification classifies the nerve fibers depending on their function and the conduction velocity.
Okay, thank you. And the next person is Lorraine Wainaina.
I'm in Group Z, and I've learned that the alpha gamma motor neuron serves the muscle spindle.
Okay, great. Then Lucy Wainaina. Unmute yourself, Lucy.
I've learned about the factors affecting the nerve conduction, which are hypoxia, pressure, and local anesthetics.
Okay, that is Lucy. Then I need, who is the next one? Prudence Ndirito. Prudence. Unmute yourself, Prudence. Mombi, if you're not able to talk, type in the chat. Type in the chat, Prudence, so that I go to The next person, Angela Mureithi.
Yes, I'm in group Z, and what I learned is that, sorry, for the second degree nerve damage, what affects it, the greater the greater the distance of the injury, the more time it takes to heal, and the less it is, the shorter time it takes to heal.
Okay. Hey, who was the person that I skipped? Prudence. Have you managed to type? Type what you have captured. Then I know that you are in class. You may not be able to talk, but you are typing. So type an answer. What you have captured. So the next person is Samuel.
I have
Samuel.
learned that, yes, I have learned that the endonucleum is the innermost membrane surrounding the myelin sheath on the axon of the neuron.
Okay. And Kushrana?
I'm in group one. I've learned that when you talk about the type 5 classification of nerve injury, it damages the perineum and has the slimmest chance of recovery.
Thank you. Yembabazi. Okay, Prudence, I've seen your answer. Kebabansi, unmute yourself. Kebabansi, Lillian. She put up her hand and then she disappeared.
here.
You are
I'm
unable to
here.
unmute yourself. Okay, go
Yeah.
ahead.
So me, what I learned today is that the type C under the Elegas something, that name, is the very slowest and is non-myelinated. And one of the examples is
Don't
the
give too many
post-ganglionic
answers because the
fibers.
others will have nothing to say. Anita.
Yeah, I'm in group Y. I've just learned that the fibers that are before the ganglia are preganglionic, and those that are after the ganglia are postganglionic.
Okay, Yash Patel.
I'm in group Y and I've learned that compression is one of the causes of injury of nerve cells and it can be repaired.
Okay, but compression has already been given, eh? So think of something else.
Crush injury is also a part of nerve damage.
Okay, so now I have who is after Michelle Mogusi.
Okay, so whenever we were looking at the Sunderland's classification of nerve injuries, we saw grade 1 is classified as the temporary interruption of myelin sheath without loss of axonal continuity.
Okay. Kerubo.
Since they've said all the answers, I'll repeat what I can remember.
We have not said everything. I can't have talked in 2-3 hours and you just give me less than 10 minutes. Kerubo.
Oh, okay. Let me see what. Yeah, I captured that.
Hold on, you're in
Though,
which class?
oh,
Kerubo.
sorry, I'm in class Z.
What is the last name?
Mochere Aibukirubu.
Yeah, there you are. Okay, so go ahead.
That though a nerve may recover structurally, it takes more time for it to recover its physiological
You see,
function.
that had not been said. And you're saying everybody has said something. Something different. Barbara.
I'm in group Z.
Yeah.
And I've learned that in the Ellen Grasses classification, in type A beta, it's a sensory, it transmits sensory observers, and it's mainly responsible for vibration, light touches, and flutters. Yeah.
Okay. Who comes after Barbara? Asna Ahmed.
I've gotten that local anesthetics mostly damage the pain fibers and they least damage the movement and touch nerve fibers.
Okay, patience. Now I'll start taking repeats.
Yes.
Hey, you're quite far.
Oh,
Patience,
sorry.
quickly. One word.
Beside the
the next class.
Beside the classification of the Elendanga, he came about those classification because he was basing about how they function and how they conduct velocity.
Okay, axilla, quickly. Axilla.
Toxins as one of the causes of the injuries of the nerves.
Okay. Now, Anay. Anay.
I'm in group Z. Under the Lloyd classification, I learned that the first three, type 1 to 3 fibers are myelinated, while type 4 is unmyelinated.
Okay. Now, Isaac, Amore. No. I have skipped somebody. Alan, Yasin.
Yes,
Alamin, sorry, not Alan, Alamin.
Yes, can you hear me?
Yes.
After my review, I've learned clearly the difference between the gas and the Lloyd classification.
Okay, what is it? Just one.
Okay, the gas mainly contains the motor and sensory, and the Lloyd is sensory fibers alone.
Oh, thank you. Now, at least you see when I called you at the beginning, you were able to capture that. Huh?
Yes.
Yeah, so it is good when I call people's names. Mugambi, Grace, you had answered, isn't it? Mugambi, you had already answered, yeah? It's even disappeared. Okay, Isaac Amori.
Yes, I'm in group Z.
Yeah.
And one of the organs originating from the muscle is the muscle spindle.
Mm-hmm. All right. Then the next person from Isaac is Philip Musila.
I'm in group Y. I've learned that in Elangagasa classification, type A delta deals with sharp pain, while in type C, dull pain.
Okay, Joy Moshami.
I had spoken.
You had spoken and you put down Winnie.
I have learned, I'm in group Z, I have learned about the A delta sensory fibers which are found in both the Lloyd and Elangagasta classification, and they're mainly for sharp pain.
Okay, that is Winnie. So I have everybody in group Z has answered. In group Y, I don't have Alisa Keno.
I'm right here.
And why haven't you put up your hand?
I didn't want to disrupt the way you were going. So if I put up my hand, you would have had a disruption in the...
No. The hand comes below.
Okay.
The hands come up in order. So the first person to put up their hand, they are up in the list. Well, the one who comes down last goes down. So if you have not answered, put up your hand. The hands will come back to the lower side. So Alice,
Yes. Yeah, under the Elangagesa classification, I learned type B fibers are purely preganglionic.
Okay, preganglionic. I think Denver has answered. Elena has answered. Madeline Kenyi Leju. Madeline is not there? Okay. I think now I have captured everybody who has not had their name. With that, have a